itself remain only 20 minutes.
Okay.
بعطيكم 20 دقيقة مع المناقشة.
You have 2 minutes presentation, 10 minutes. Sorry, I took long. It's all his fault. It's meant to be the first one because it is never trust what yours own.
Good morning, everyone. This case, we're about to present Ondine scars and stroke. It's a myth where it meets reality. So, this is Dr. Bikral Wattar, Consultant General of Respiratory Medicine. Thanks for her. This is Dr. Rashid in the middle. He's a stroke consultant. His team managed this case while Dr. Dikra was in the OA. Okay. This is me, graduate of this year. So, for the case, the case is a woman. She's a 53-year-old female with 24-hour history of vertigo. She had double vision and unsteady gait. Her past medical history includes tonsillar cancer, for which she was treated in 2011. She does not take any regular medications and does not have any allergies. She's independent, works as a system analyst, and has an active lifestyle. Her family history is negative. Now, what would we like to ask about this case? Importantly, we would like to know the onset. So in this case, it was acute. We would like to know if there are any ear symptoms that exclude Ramsay-Hunt syndrome. And importantly, one of the serious differential diagnoses is vertebral artery dissection, which includes, we have to ask about the pain, recent trauma, neck manipulation, as we see in this picture. We have to ask also about previous episodes, and also drugs, alcohol, and smoke. So on examination, she had mild dysarthria. She had left facial droop and loss of reduced coordination in the left lower limb. But this was with normal tone and power. So what is the clinical diagnosis? We see these symptoms, we think of a stroke. So we immediately send her for investigations, which include lipid profile and the clotting screen. An ECG was also done. And most importantly, we sent her for CT head, with or without CT angio, which was to be decided later on. So this is her CT head result. We can see clearly here a well-defined hyperintense lesion located in the brainstem, which confirms the diagnosis of hemorrhagic stroke. Okay, so CT angio was done, and we see this hemorrhage in the middle. This was to rule out if there are any aneurysms, cavernoma, AV malformations, which could also occur in this case, other sources of bleeding. So in this case, it was ruled out. They were not present in the CT angio. Now for the management. The initial management for this case was to take an ABCDE approach and treat the patient accordingly. This case had to be managed in an acute care unit, like a stroke unit or an ITU or CCU. And also blood pressure management is crucial here, which we will talk about in the following slides. Speech and language therapist was also needed for assessment. And we also have to check coagulopathies. And if the patient is on anticoagulation, we have to reverse it. So no aspirin should be given at this point. There was also supportive management. If the patient had fits, we have to give anticonvulsants. And also VTE prophylaxis and neurosurgical referral if needed. Now, for the blood pressure management, this patient was a candidate for lowering her blood pressure. She had an acute onset of less than 6 hours, and the target blood pressure was 140. So one of the drugs that we can use is labetalol. Has to be an infusion form, and also GTN infusion or patch. If the patient could not swallow, we can use an NG tube and give oral agents. And for the progress, the SOL team reviewed her, and also physiotherapy. The team planned for an MRI. This was because of her history of tonsillar carcinoma. So one of the important differential diagnoses was like a hemorrhagic metastatic lesion that could also occur in this case. the patient was not medically fit for discharge because of this. So it remained inpatient. Now, this was the MRI that was planned. It did not show any metastatic lesions. And it also showed the stroke here. Okay, so we're now at day 7 after admission. The patient was not feeling well, so the doctor seen her and did examination. This was in late evening at 10 p.m. So it had mild hypoxia. So they did an ABG. It showed that she had acidemia and high CO2, PCO2. So the plan is to do chest X-ray and repeat the ABG to see the progress. Now, what could be the cause behind hypoxia post-stroke? We could think mainly of 2 things: be an infection, aspiration, and we could think of maybe a PE, pulmonary embolism. One thing also could be like a neurological change and airway compromise, but the main things are those 2 in the first. So this was her chest X-ray. We can see this lesion, well defined. This was right lower zone consolidation. Her ABG was still acidotic with high PCO2. So this plan is to treat her as an aspiration pneumonia. Bloods were sent, white blood cell and CRP. Yeah. So the saturation was changed. The target saturation was changed to 88 to 92%. So this was happening slowly. Now later at that night, at almost 3 a.m. in the morning, the patient could not wake up, seen by the nurse. So she called the F1 doctor in charge, and they did an examination. The patient was found to be in respiratory arrest. She was apneic and hypoxic. Now, full assessment was done. From the airways, an oropharyngeal tube, airway was inserted. She was giving 15 liters of O2, and her Glasgow Coma scale was 3. There was no clot swelling, no remarkable abdominal examination, epidurال. Now, the diagnosis, according to the ABG, was type 2 respiratory failure. So she was intubated in ward by the ITU team and then transferred to the unit. The family was attending this discussion with the patient because the patient was in critical condition and was at the risk of dying. So this is the CTPA. Did not show any pulmonary embolism, which was one of the differentials. It showed significant patch inflammation and segmental collapse of the lower lobes. Now, she was stable in the ITU and was followed 24 hours later. She was successfully extubated. Now she had sinus bradycardia and started BiPAP for type 2 respiratory failure. Now the ENT were involved because of her tonsillar carcinoma history. They showed the examination was reassuring and did not have anything significant. Also the MRI was also reassuring. Now one of the other differential is aspiration. So we checked this swallowing, and we did updated fluoroscopy video and showed normal swallowing. Okay. So she had central hypoventilation secondary to her stroke. Now, for the interesting part, this is Ondine's curse. Ondine's curse is a central hypoventilation syndrome. It can result from anything. Now, for the story, this is Ondine. This one here. She's like a mermaid that had Orion. She has a long life, so she cannot die. Okay, so her this ability cannot or will break if she marries a normal human being. So she loved this guy, and he pledged faithfulness to me with every waking breath. So she wanted him to be faithful to her because she sacrificed her long life for this man. So one day she found him cheating on her. So she reminded him of this pledge that he would give her every waking breath. So she cursed him. As long as you're awake, you shall breathe, but should you ever fall asleep, your breathing shall cease. So the minute he falls asleep, he will not breathe. So this is the story behind Ondine's curse. Now, Dr. Dekra will continue about the details of Ondine's curse. It's very interesting. Thank you.